In this coronal anatomical section, we note that a pink plastic was injected and fills the superior vena cava, the right atrium, the inferior vena cava, and the coronary sinus. Note that to the right of the right atrium, we see fibroadipose tissue, and it forms what is called the right pleuropericardial fat pad, which is a collection of fat interposed between the right medial dome of the diaphragm, lateral to the right atrium, and inferior to the angle between the medial and inferior aspect of the lung. And this fat pad can simulate a prominent right atrium in underexposed frontal view of the chest. Note that to the left of the heart, between the left ventricle and the lung, is the pericardial stripe. We also note that between the pericardial stripe and the free wall of the left ventricle is the epicardial fat, and lateral to the parietal pericardium, that is lateral to the pericardial stripe, between the pericardium and the mediastinal pleura, there is also fat. And this fat plane is called the left pleuropericardial fat pad, which again on frontal views of the chest, it can mimic or can simulate enlargement of the heart in the transverse position. In this anatomical coronal section, we note the innominate vein entering the region of the superior vena cava. We note the ascending aorta with the sinus of Valsalva. And we note the thickened wall of the left ventricle. And to the left of the ascending aorta, we note the pulmonary trunk. In this person, we note a density to the right of the right atrium. The question is, where could that mass be located? Is it arising from the lung? Is it arising from the pleura, from the pericardium? Is it a pericardial cyst? Could it be a herniation of omentum or of an abdominal organ into the chest? Could it be a tumor of the diaphragm? Could it be subdiaphragmatic? CT is an imaging modality specific for recognizing fat. Note that we see a large pleuropericardial fat pad between the anterior chest wall, the medial aspect of the right lung, and the heart. So if we have doubts as to the possible nature of a mass in the angle between the heart and the right dome of the diaphragm, CT should be the modality of choice. This is a normal frontal chest röntgenogram on a 48-year-old internist who gave a history of a slight dysphagia. The lateral chest röntgenogram of the same patient shows a mass in the retrocardiac region silhouetting the posterior wall of the left ventricle. There was a suspicion of a hiatal hernia causing this mass. A barium study of the esophagus revealed displacement of the esophagus to the left, but the esophagogastric junction was at its normal site. So we were dealing with a juxtaesophageal mass that did not correspond to a hiatal hernia. This is an old case that was studied with one of the earlier CT machines. We made a color rendition of the structures, labeling in yellow the fatty structures, in orange the muscle, in white the bony structures. Here you can see distinctly a mass between the heart and the descending aorta, projecting primarily to the left of the midline. Note that it has the same CT values as the fat that surrounds the heart and is seen in the subcutaneous region. We therefore made the diagnosis of a fatty tumor, and we suspected that this was a simple lipoma of the mediastinum. The thoracic surgeon in this case wanted to operate on this patient and was reluctant to do a CT examination. CT, however, revealed the exact nature of this mass, and this patient has been followed for more than 15 years, and the mass did not grow, and there were no symptoms referable to this mass. So it was retrospectively a benign lipoma of the mediastinum. This is a patient that showed on the frontal chest rentgenogram to your left a widened lobulated mediastinum, suggesting the presence of a mediastinal tumor. The picture to your right is the left lateral view of the chest, showing the anterior bowing and displacement of the trachea, and the lobulated mass that presented primarily in the posterior mediastinum. The patient gave a history of dysphagia and of shortness of breath. CT examination revealed in the chest a heterogeneous density that appeared in the posterior mediastinum. Note in the abdominal cut that the density extended into the abdomen in the retroperitoneum, and it is seen in front and to the right of the abdominal aorta. The CT value that predominates is low, but interspersed areas of high CT values suggested that this was not a simple lipoma. At autopsy, this patient proved to have a very extensive liposarcoma of the mediastinum and extending into the retroperitoneum. Intrathoracic fatty masses include lipomas, which are among the most common soft tissue tumors in man. They can be classified as totally intrathoracic or hourglass type. The total intrathoracic can be mediastinal, can arise from the thymus, can be subpleural, pericardial, or endobronchial, and 88% of these patients are males. The hourglass type is cervical mediastinal. In other words, there is a mass that projects at the base of the neck, or it can be transmural, which means that there is a mass that is seen also lateral to the rib cage. The age of discovery is from infancy to 7th decade. They become symptomatic in about 50% by virtue of size and location. Now, liposarcomas occur about once for every 120 lipomas. 8 out of 300 fatty tumors that prove to be liposarcomas occur in the mediastinum. And this is from a large series from Mayo Clinic and Memorial Hospital in New York. Other fatty processes that can be seen in the chest are the fat pads that we previously described, exogenous obesity, or what I call the mediastinal adiposity, as seen in obese individuals, and particularly those patients taking corticosteroid medication, Cushing's disease or Cushing's syndrome, herniated omentum, and a very special fatty tumor that is seen in bears and rarely in different parts of the abdomen and retroperitoneum, called hibernomas. If the frequency of liposarcoma above the diaphragm is so low, and again from 2 series we saw 8 out of 300 liposarcomas occurring in the mediastinum, what is the point in removing possibly benign fatty masses in the mediastinum? However, we should be cautious, because if there is a rapid growth of a mass that appears to be benign because of the uniform low CT values of the mass by CT or the brightness by MR examination, or if the mass becomes symptomatic, and again we saw that about 50% of lipomas can become symptomatic, or if there is a non-homogeneous mass by CT, the patients may have a liposarcoma. It is important to recognize that some benign teratomas may have a lot of fat and produce a non-homogeneous mass by CT examination and still remain benign histologically. Nevertheless, we believe that any fatty mass that is heterogeneous as far as its appearance by CT should be explored because of the possibility of a well-differentiated liposarcoma being present. This is a spectacular case that showed a very huge heart, between quotes, and widening of the superior mediastinum. Overall appearance of the mediastinum and heart is of a triangle. And note that the borders of this triangle are relatively straight line. Note that we can see the hyla, and because we see vascular markings through this mass, the fatty nature of the mass should be suspected. Also note that the widened mediastinum extends cephalad from the aortic arch. So therefore this mass cannot be related to the heart and cannot be related to the pericardium. The pericardium attachment is at the origin of the brachiocephalic arteries, and because of the widened mediastinum, extending above the plane of the aortic knob, it cannot be related, this mass, to a distended pericardium. The patient was relatively asymptomatic. The lateral view of the chest also shows a triangular mass that encompasses the heart, surrounds the heart, above it and behind it, and touches the posterior chest wall. The posterior margin of this mass is pretty sharp. Note that the only dome of the diaphragm that we see is the left hemidiaphragm, because we can see markings through this mass, and because normally pleural effusion produces a concavity where the lateral portion of the concave portion is against the chest wall, and here we see an acute angle between the posterior aspect of this mass and the chest wall. A pleural effusion was not considered. Again, a large mass in a relatively asymptomatic or an asymptomatic individual where we can see markings through the mass, we must suspect the benign nature of the mass that most likely is composed of fat. Because of the location of this mass occupying the anterior, middle, and extending less to the posterior mediastinum, we suspected a thymolipoma, and this was proven at surgery. A CT examination of this mass revealed the fatty components that predominated, but this mass was heterogeneous. Again, although it turned out to be a thymolipoma, it was warranted to explore the mass because low-grade liposarcomas can show similarly by CT examination. This is another patient with a thymolipoma. Note that we see a mass extending lateral to the left ventricle and touching the left chest wall. Both in the frontal view of the chest to your left and in the lateral view of the chest to your right, the triangular shape of this mass is very apparent. And the base of all the thymolipomas are towards the diaphragm. And note in the lateral view of the chest a similar appearance to the previous case, that the posterior margin of the mass might resemble a pleural effusion. However, pleural effusion tend to rise more dorsally than ventrally. And also note that we only see the right dome of the diaphragm. The fact that the patient was asymptomatic and that this mass had this triangular appearance should make one suspect the possibility of a thymolipoma. A CT examination revealed the fatty component of this mass, and at surgery proved to be another thymolipoma. This is another density that is seen along the left heart border. We can see the hilus through this density, and it proved to be another small thymolipoma. The CT examination showed the fatty nature of this mass. The last air soft tissue interface that we're going to discuss is the anterior junction line, which occupies the anterior mediastinum. In this axial section, with the aorta sitting in the center of the heart, we note the anterior right ventricle and outflow tract of this chamber that contacts the chest wall. There is interposed air that comes from the right and left upper lobes, which touch each other in front of the heart. This doesn't happen always because abundance of fibroadipose tissue may not make possible the two lungs to come in contact in axial images of the chest. Note the right lung projecting more medial than the left lung. And again, the contact between these two anatomical structures form the anterior junction line. Tony Proto has sketched the anterior junction line as a straight line which can be vertical or slanted, as indicated in the left diaphragm. It extends always below the plane of the clavicles and branches and disappears in front of the heart. So it becomes an inverted V of victory as the two lungs separate from each other caudally. Note that the anterior junction line will always outline the anterior heart border, the pulmonary trunk and the aorta, only if the patient has no masses in this location or fibroadipose tissue that may not allow the two lungs to come in contact with each other. In this frontal view of the chest, we note that the anterior junction line, which appears as a vertical stripe on both sides. We see the anterior and medial position of the right and left upper lobes. Note the shortness of this line, and as it is visualized towards the heart, it diverges and disappears. There are numerous anatomic variations and pathology which makes the anterior junction line a structure that is of less importance than the pleuroesophageal line, the posterior junction line, the paraspinal lines, and others. In this lateral chest rentgenogram, we see aerated lungs covering the anterior aspect of the heart. In this area will be the right ventricle. Above it, the anterior aspect of the pulmonary trunk, and above it will be the ascending aorta. All these densities blend with each other. The reason we can see the anterior cardiovascular structures is because aerated lung covered the heart and the vessels, and in this patient there was virtually no fibroadipose tissue in the anterior mediastinum. In this obese subject, we do not see the anterior junction line. Note that there is no widening of the mediastinum. This is the lateral view of the chest of the previous patient. Note that the anterior heart border is grayish, and there is unsharpness of the cardiovascular structures because of abundance of fat in the anterior mediastinum. So the absence of the anterior junction line in this patient is not due to pathology. Is simply an anatomical variation related to excessive fat in the anterior mediastinum. We can also see abundance of fat in patients with Cushing's syndrome or Cushing disease, and in general in patients with exogenous obesity. This is an anatomical specimen of a very obese individual. After removal of the sternum, one can observe the presence of fat, and it is so abundant that it not only separates the two lungs, but it prevents us from seeing the anterior cardiovascular structure. So we would have to dissect through this fat to be able to see distinctly the parietal pericardium. The lungs are partially collapsed, and that contributes to the fact that we do not see proximity of the right and left upper lobes that normally should form the anterior junction line. In vivo, this patient probably did not have an anterior junction line because of the abundance of fibroadipose tissue in the anterior mediastinum. The three masses of the anterior mediastinum start with the letter T, and in order of frequency, thymic masses are the number one. In children, the thymus is a normal structure. It can grow up to the age of 12 or 15, and it becomes radiographically apparent in early life. Note that the widened superior and inferior mediastinum is due to the enlarged or prominent right portion of the thymic gland. When the thymus enlarges, it may grow asymmetrically, and because of embryologically it starts at the base of the neck, it can be seen all the way down to the diaphragm. So this accounts for the most common abnormalities of the mediastinum in infants and children. That is a prominent thymic gland. A large thymus should not be considered a pathological situation. On the contrary, generally the healthier a baby, the larger the thymus. Conversely, a sicker a baby, the smaller the thymus. The thymus is like a spongy structure which is generally incapable of compressing or displacing the airway, that is the trachea and the bronchi. So a patient with difficulty breathing or swallowing and a large mass due to the thymus, the mass should not be considered the cause of the shortness of breath, and we should think of another type of pathology and not relate the symptoms to the prominent thymic gland. This is an anatomical specimen after opening the chest and photographing the anterior mediastinum, where one can see the very large thymus, even larger than the heart. Note the asymmetric growth of the thymus and that it extends from the thoracic inlet all the way down to the diaphragm. And this is a specimen that corresponded to the previous patient. There was no abnormalities whatsoever related to the thymus. In this patient, a discrete density outlined by the arrows was noted at the junction of the vascular arch and the right atrial border. A differential diagnosis would include a adenopathy, a mass arising from the middle or anterior mediastinum, a prominent ascending aorta, perhaps a sinus of Valsalva aneurysm. In the lateral view of the chest of this patient, one can see a discrete density that is projected in front of the right hilus that is superimposed to the heart. The patient was asymptomatic and refused any further investigation at that time. 3 years later, the patient returned, and the frontal chest röntgenogram shows now enlargement of the mass. In the lateral view of the chest, we note the mass now extending into the anterior mediastinum, and most of the mass overlaps the cardiac shadow. This is a frontal tomogram showing the lobulated nature of the mass. This is a lateral tomogram where the sternum is to your right and shows the right prehilar lobulated mass. The most likely possibility would be a thymic tumor. At fluoroscopy, pulsations were noted at the level of the mass. It must be remembered that a mass that is adjacent to the aorta or to the heart may have transmitted pulsations, and not always it is easy to differentiate the intrinsic from transmitted pulsations. Because of the lobulated nature of the mass, we suspected that this would be a solid or cystic tumor. The surgeon thought that the mass might be related to the ascending aorta and requested an aortogram. We requested non-invasive imaging modalities first because we felt that they would give the diagnosis. And this is an echocardiogram which shows that the mass is lateral to the diamond-shaped echoes of the aorta. So it is not related to the ascending aorta. A radionuclide angiocardiogram shows a normal ascending aorta, and lateral to the right atrium and to the ascending aorta, we see the focal photopenic mass, which at surgery proved to represent a thymoma. In this frontal chest radiograph, we note bilateral masses that probably are located in front or behind the hyali. A T2 weighted image shows the high signal at the level of this mass. This proved to be a cystic tumor, and it turned out to be a thymic cyst. So thymic tumors can either be primary lesions of the thymus, cystic lesions of the thymus, benign thymomas, malignant thymomas, and carcinomas, as well as lymphomas of the thymus. In this frontal view of the chest, we note a large bilateral mediastinal process, more to the left than to the right. MR examination shows the bilaterality of the mediastinal mass. The largest component is noted to the right of the heart. This is a coronal MR examination showing a tumor to the right of the ascending aorta and adjacent to the left side of the heart. A coronal MR section reveals the mass on both sides of the midline. The margins of the mass appear ill-defined, and therefore we should consider a malignant tumor. This proved to be a malignant thymoma. This mass at the junction of the vascular arch and the right atrial arch of the right heart border was suspected of being a thymic tumor. at the surgery, this proved to be an ectopic parathyroid carcinoma. We know that the inferior parathyroid glands originate in the neck with the thymic gland and can migrate into the anterior mediastinum. So a mass in the anterior mediastinum or close to the heart in this region should be considered either a thymic tumor and less likely, but possibly a tumor arising from ectopic parathyroid glands. In this CT examination, we observe a mass to the left of the heart, and it corresponded to an ectopic parathyroid carcinoma. In this child, we note a mass to the left of the midline with a calcification within the mass. On careful scrutiny, this was a tooth, and this finding is virtually pathognomonic of the second T of the anterior mediastinum, which is a teratoma. In this baby, the widened mediastinum was suspected to represent an enlarged thymus. However, the baby had difficulty breathing and difficulty swallowing. We note in the lateral view of the chest to your right, a narrowing of the trachea. And we know that this would not be produced by the thymus. Therefore, although there is no calcification at the level of the mass, and the mass was seen in a baby, the most likely diagnosis was teratoma, and this was confirmed at surgery. So any difficulty breathing and difficulty swallowing with structural changes at the level of the esophagus or the trachea should be suspected of being not related to a normal thymus, but to some other tumor of the mediastinum. This is a frontal chest radiograph of a patient who had some difficulty breathing. At first glance, we note that the lungs and heart are radiographically normal. However, note the lateral displacement of the trachea, and the plain percentage, the most common cause of this displacement should be the thyroid gland, which is the third of the anterior mediastinal masses. This mass proved to be a goiter. In the lateral view of the chest, we note the mass in the anterior superior mediastinum, which suggested an intrathoracic extension of the goiter. This was proven by scintigraphic examination. This is an atypical presentation of a goiter. Note a large mass, which could be related to a lung tumor, to a pleural tumor, to a mediastinal tumor. Note also that the trachea is not displaced, and this proved to be due to a thyroid mass. And not always we can be sure about the nature of the mass, and other tests are essential, such as scintigraphy. The thyroid masses are usually seen in the anterior superior mediastinum and at the base of the neck. They classically displace the trachea to the right or to the left. Occasionally the thyroid masses interpose between the trachea and the esophagus, and sometimes they are quite large and project inside the thoracic cavity, mimicking, like in this case, a lung or pleural tumor. In this lateral view of the chest of the same patient, note the large, well-circumscribed mass, which occupies the anterior, middle, and posterior mediastinum. No calcification was seen within the mass. Note also that calcific densities can be seen in any of the three T's. That is, can be seen in the thymus, can be seen in teratomas, as well as in goiters. In teratomas, calcific densities can appear as a bone or as a teeth, something that you will not see with thymic tumors or with goiter. This is a scintigraphic examination of the thyroid gland. Note intense uptake of a substernal thyroid goiter. Adenopathies are the fourth mass that we should consider in the anterior mediastinum. In this patient, metastatic nodes from a breast cancer to the right internal mammary chain were observed. We can see adenopathies not only with the metastasis, but also with lymphomas and with granulomatous disorders such as sarcoidosis. This patient shows metastatic nodes in the anterior mediastinum, and the primary site was a thymoma. Once again, lymphoma, metastasis, and granulomatous disorders can enlarge nodes in any part of the mediastinum. The home of adenopathies is the middle mediastinum, but enlarged nodes can be seen in any of the three compartments, including the paravertebral or paraspinal regions. In the anterior superior mediastinum, we have some vascular structures. The superior limit of the anterior mediastinum can be traced to the clavicles, but also to the left innominate vein. In this coronal section, we can see the left innominate vein crossing from left to right to eventually terminate in the superior vena cava. The superior vena cava, right atrium, and inferior vena cava appear in pink. Note the ascending aorta, and lateral to the ascending aorta, the pulmonary trunk and the origin of the left pulmonary artery. The aorta rises from the left ventricle. Note also fibroadipose tissue that surrounds all these mediastinal structures. In this lateral view of the chest, we see a close-up of the anterior superior mediastinum. Note the indentation of the pleura by the left innominate vein. Indentations of the pleura are caused by vascular structures, but also can be seen from osseous structures, as will be noted in the next case. To your left, we see indentation of the pleura and the anterior superior mediastinum. A differential diagnosis will be the left innominate vein or the possibility of osteophytes. To your right is a close-up of the junction of the anterior right first rib with the sternum, and note a prominent osteophyte, which was the cause of the density seen in the anterior superior mediastinum in the lateral view of the chest. This is a specimen from Dr. Proto and Dr. Heitzman's work, which shows the anterior wall of the superior vena cava as a structure that can be seen on plain radiographs. Note this lateral chest radiograph, which shows in black arrows the left innominate vein, and in white arrows the anterior wall of the superior vena cava. Note that it parallels the trachea and is a normal air soft tissue interface that we see in the lateral views of the chest. This is another specimen of the Proto-Heitzman collection, which shows the innominate artery as outlined by the arrow. It produces a gentle curve that is superimposed to the trachea in its inferior portion, and the superior portion is usually dorsal to the trachea. In this lateral chest rentgenogram, we can see the innominate artery crossing the shadow of the trachea. The inferior aspect of the innominate artery, close to its takeoff, is convex inferiorly and dorsally. The cephalic portion of the innominate artery courses towards the neck and is more or less vertically oriented, but is noted close to the posterior wall of the trachea. Here we see three vascular structures. The lower arrow corresponds to the superior vena cava. The middle arrows, which are two, show the shadow of the posterior wall of the innominate artery. And the horizontal superior arrow shows the origin of the left subclavian artery. So again, we see the superior vena cava inferiorly, the innominate artery above it, and then the left subclavian artery is the last structure seen in the thoracic inlet. The lateral projection of this injection shows the opacification of the left brachiocephalic vein, which again forms the superior limit of the anterior mediastinum, and occasionally can indent the pleura as it crosses from left to right. Injection of the left antecubital vein opacifies the left innominate vein, which, as you can see, is directed from left to right and terminates to the right of the midline in the superior vena cava. In this infant, we note the density in the right cardiodiaphragmatic angle as outlined by the arrows. The differential diagnosis would include a pulmonary lesion, a diaphragmatic process, something arising from the right pericardium or right atrium, or the intrathoracic herniation of an abdominal structure. This baby had a pneumonia in the right upper lobe. The lateral view of the chest of the same child shows that there is an air bubble in topography of this density. This is a pathognomonic of herniation of the bowel into the chest. It could have been stomach, but most likely it would be the colon. And the herniation is through the persistence of a right foramen of Morgagni, which is a congenital defect of the anterior medial aspect of the diaphragm. A barium enema shows the herniation of the transverse colon through a persistent foramina of Morgagni. Sometimes on barium studies, we do not see the bowel in the chest, but instead of observing a transverse colon that is convex inferiorly, it becomes convex superiorly. In such a situation, the hernia of the omentum pulls superiorly the transverse colon, and the density that we see in the costodiaphragmatic angles then represents the omentum. And we can be sure about the omentum if we note the abnormality in the course of the transverse colon, and by CT or MRI, we confirm the presence of fat at the level of the density. This elderly patient was asymptomatic. Note the frontal view of the chest that shows scoliosis and a mass in the inferior aspect of the right hemithorax. It is probably not related to the heart because of the morphology of this mass. The lateral chest rentgenograms is pathognomonic of what was later found, and that is that the right lung appears hypoplastic because it does not reach the anterior chest wall. The reason for that is that inferiorly it has the heart, and superiorly fibroadipose tissue. Note that we only see one dome of the diaphragm, which in this case was the left dome of the diaphragm. It's the only part of the diaphragm that was covered by lung. Behind the heart, in the posterior mediastinum, or the anterior aspect of the thoracic spine, we see the density. And when we see this constellation of findings of a hypoplastic lung, a density projecting into the right hemithorax, and dextroposition of the heart, we must think in the presence of a hernia. Opacification of the stomach and bowel revealed a distorted duodenum. Note that is directed towards the right dome of the liver. And there is also a high position of the bowel in the right upper quadrant. A barium enema showed a high position of the hepatic flexure of the colon. In view of these findings, one has to suspect that either the liver is very small, or that the liver or portions of the liver are in the chest. When there is a reduction of the size of the liver, as seen in atrophic cirrhosis, the colon occupies a high position, and there may be a distortion of the proximal small bowel. And in this patient, then because of the mass seen in the chest rentgenogram, one has to assume that we're dealing with a diaphragmatic hernia with the liver in the chest. Scintigraphic examination shows distortion of the liver with a portion of the right lobe of the liver in the thoracic cavity. So this patient did not have a mediastinal tumor. The abnormality was herniation of the liver into the chest, that is the right lobe of the liver. 20 years before, the appearance of the chest was exactly the same as it was noted in the original chest rentgenogram that we showed you. So remember that whenever we see a mediastinal mass that occupies the inferior portion of the mediastinum, and the mass contacts the diaphragm, we must always rule out the possibility of herniation of an abdominal structure in the chest. The herniation can be an organ such as the stomach, a small or large bowel, can be herniation of the kidney, or can be herniation of the omentum. And in the anterior inferior mediastinum, we must suspect the omentum, stomach, or colon, and on the right side, herniation of the liver. This patient had a routine chest rentgenogram because of respiratory infection, and a mass was noted adjacent to the right dome of the diaphragm. It can be seen in the frontal to your left and in the right posterior oblique view of the chest seen to your right. Note that the right margin of the mass is rectilinear. The question is, are we dealing with an intrapulmonary mass? Are we dealing with a pleural tumor? Could this be a tumor arising from the diaphragm? Or could it be conceivably a herniation of an abdominal organ in the chest, like perhaps the liver or the adrenal gland or the kidney? Part of the workup of this patient was an intravenous pyelogram, and it showed that the right kidney was in the chest. And note the arrow pointing towards the pelvocalceal system of both kidneys. The left kidney was in a normal position and is seen through the air in the stomach. Now, why is it that the kidney has this particular shape? The reason is that whenever we deal with renal ectopia, be that in the chest or in the abdomen or pelvis, the kidney may lose the coffee bean shape. And it is not unusual to see a bulbous upper pole when the kidney ascends close to the domes of the diaphragm, or to see an appearance that almost looks like quadrilateral when the kidney is above the diaphragm, as in this case. So this patient had a herniation of the kidney into the chest. It's a high ectopia, and this was due to a posterior defect of the right dome of the diaphragm. Mediastinal masses can be the result of lung tumors, particularly in the anterior mediastinum. Remember that the two upper lobes can contact the anterior cardiovascular structures. A tumor in that location of the right or left upper lobe close to the midline can mimic the presence of a primary mediastinal tumor. In this patient with emphysema, a large mass was seen adjacent to the mediastinum. The appearance suggested a carcinoma of the lung, which was confirmed with the needle aspiration biopsy using the suprasternal approach. When a patient has COPD, the transthoracic biopsy of the mass may be complicated with a pneumothorax. One safe way of sampling mediastinal or juxtamediastinal masses in patient with COPD is to use the supra or parasternal approach. This proved to be a squamous carcinoma of the lung. This patient also presented with an anterior superior mediastinal mass, and a suprasternal biopsy of this mass revealed a thymoma. In the lateral view of the chest, we note the position of the biopsy needle. This is a safe procedure when performed under fluoroscopic control, and usually using small trocars. This is a very effective way of demonstrating metastasis, and the histology of metastatic tumors is easier to be made than lymphomas. But also lymphomas can be diagnosed by this mediastinal approach to biopsying tumors. This was a mass in the anterior superior mediastinum. The infra or parasternal approach was utilized, and the diagnosis was of a thymoma. In the lateral view of the chest, we can see the catheter with a curved wire. The approach to this mass was to first puncture the anterior mediastinum with a straight trocar, pass a guide wire, and through the guide wire a catheter, and inside the catheter a biopsy needle was advanced, and that is how the tumor was sampled. The diagnosis again was a thymoma. This is a frontal chest rentgenogram of a patient with kyphoscoliosis. Note a left juxtahilar mass. The patient was sent for biopsy of this mass. The patient was asymptomatic. In the lateral view of the chest, we note the severe kyphoscoliosis, but no mass could be seen. An aortogram was obtained, and we can see buckling of the descending aorta. In patient with kyphoscoliosis, tortuosity of the abdominal aorta can simulate the mediastinal mass. And obviously, prior to biopsy, we must make sure that we're dealing with a vascular structure and not with a tumor. In this other example of a thyroid carcinoma, we can see the hypervascularity at the level of the tumor, which is displacing to the right the innominate artery and also the right common carotid artery. When biopsying hypervascular masses, we must use either a fine needle technique or do an open biopsy. Under no circumstances we should use trocars that would be larger than an 18-gauge needle. This is another example of a hypervascular mass which proved to be a hemangiopericystoma. Note the displacement of major vessels and the intense hypervascularity. When clinically we suspect a hypervascular mass because of the presence of dilated superficial veins in the skin or increased temperature or a bruit, we must do an angiogram preceding the biopsy of this mass.